Good evening, everybody. My name is Randy Kojima, and it's my pleasure tonight to share with you some of my experiences with scleral lenses. Tonight's webinar has been sponsored by Precision Technology and Paragon Vision Sciences. It's interesting to me how I've really changed in how I look at contact lenses, and especially cases like this where I really believe that it was possible to find a rigid lens that could fit every eye, and it has turned out to be very foolish to think that we could possibly fit an eye that has so much asymmetry. For instance, we take this patient that has a high elevation in their corneal surface, then a low elevation where we get this bubble, then again the high elevation, and then again a low elevation. So this eye has so much asymmetry running through the vertical meridian. And what contact lens do we have available to us that allows us to fit that kind of shape? And the same thing we see in this eye, where the cornea is very low in elevation, we get this vault. Then it's high in elevation, we get the bearing. Low, we get the vault. High, we get the bearing. Low, we get the vault. So what kind of contact lens will actually align to that kind of surface? And this is where scleral lenses are really beneficial, and where I should have been thinking more appropriately about the kind of asymmetry that we deal with in some of these keratoconic and post-surgical corneas. I'm sorry, just a couple technical difficulties. There we go. So here we've got a patient that came in and presented with pellucid marginal degeneration. You can see that in the upper right-hand corner. We've got a against the rule irregular astigmatism. And you look at the elevation map just below that, and we see a high elevation in the red. That's where a corneal GP would hit first and hit heaviest. Then it has to find an opposing point of bearing, so it's going to find this other high point opposite to it. And that would give us this theoretical fluorescein pattern that we see here. Now, how is a corneal GP going to adequately fit this cornea when we've got landing at 12 o'clock, landing at 6 o'clock, and all this elevation arcuately around 9 o'clock, inferior to 6, and around to 3 o'clock? And that's why we chose to fit this patient with a scleral lens and just vault over top of all this corneal asymmetry. And you see that in the fluorescein pattern, where we've got this wild elevation or this wild amount of fluid between lens and cornea. We don't care how much asymmetry exists underneath there, because we're going to land on where the surface of the eye is more symmetrical on the sclera and just vault over top of what's in the center. So let's start with the case, a patient with bilateral keratoconus, the right eye being a little more advanced than the left eye. We'll take our corneal topography, and you can see we have a steepest radii of curvature of around 68 diopters. It's a fairly droopy inferior cone. Probably going to be a real challenge for a corneal GP to want to center on this eye. So we chose a scleral lens and went to our ICD fitting guide. And what you see here are the lenses are labeled according to sagittal depth, starting with the lowest sagittal depth at 3,900 microns and then going up by 100 micron increments. Each lens is 100 microns higher in depth at the peak than the next. So if you have an utterly normal cornea, a normal shape eye with ocular surface disease, you would go straight to a 4,200 depth lens. That would be the average lens you'd require for the normal eye. If you had a keratoconic patient, they tend to be much higher in depth, around 200 to 300 microns higher. So you would therefore select from your ICD set the 4,500 micron SAG lens. If you were dealing with a bulging transplant, then you might go up even higher, another 300 microns higher, and choose the 4,800 micron lens. And then if you have an extremely high depth eye where it's a keratoconus globus or an awesomely bulging graft, then you might go up to your highest sagittal depth lenses. But for the most part, a 42 and a 4500 micron SAG lens will fit most of the patients that come through the door as a starting point. Now let's presume that we took that keratoconic patient and instead of choosing the 4500 lens, which is the ideal starting lens for a keratoconic patient, we goofed up and we fit 300 microns lower. Instead of choosing the 45, we chose the 42. What would happen? And of course, with the sagittal depth of lens much lower than the sagittal depth of eye, we get a lens with heavy bearing on the cone or some kind of corneal bearing. So by not having adequate depth, we haven't cleared corneal tissue, but oddly enough, this patient is very comfortable. Now, how is it possible that we could have this heavy bearing on the cone and yet the patient is comfortable? And it simply comes down to movement. There's enough shared bearing of landing out here that this lens would actually center and would actually be comfortable. But would it be healthy? Of course not. This would be a very poor scleral lens fit. So let's go higher in depth, but the question is, how much higher in depth should we be going? Should we go up 100 microns to clear the cone? Should we go up 200, 300, 500, 600? How much higher should we go? Now, whenever we see a lens that hasn't cleared corneal tissue, if it's bearing on the cornea with our initial diagnostic lens, we would want to go at least 300 microns higher. Your starting point with the ICD should be 400 microns of apical clearance on insertion, and that allows for the lens to settle. If we're a little bit conservative and go up 300 microns, we should clear the cornea, but the question is, would we have enough vault between lens and cornea? So without doing an optic section, we don't know for sure. All we can say at this point is by going up to the 4500 micron lens, the lens that was recommended by the fitting guide, we have now cleared the cone. We don't have any corneal bearing. So this is good. If you have an OCT, this is a great instrument for measuring the actual apical clearance between lens and cornea. And in this case, after doing OCT, we were able to determine on insertion we had 230 microns of apical clearance. Remember that our target, at least at Pacific University, is to have approximately 400 microns on insertion, and that allows plenty of room for that lens to settle. So with only 230 microns on insertion, that may not allow enough volume of fluid between lens and cornea to allow for the settling that will happen. And we'll talk more about the settling throughout the webinar. Now here's the same patient after 4 hours of lens settling. So we sent the patient out the door for 4 hours and we want to observe how that lens settles. These lenses take hours to completely sink into the conj, so the longer you can have them in the lens, the better before you do your initial diagnostic. Now, is that possible for every patient, 4 hours of settling? Of course not, but go as long as you can. The longer you go, the more clear the picture becomes. Then we pull up OCT. We see that this patient only had 30 microns of settling. Initially, we were 230 microns of apical clearance, and we've only lost 30 microns. We're now down to 200 microns after the 4 hours of settling. So we'd call that an acceptable amount of fluid between lens and cornea. If that lens will settle no more and 200 microns is the final amount of fluid between lens and cornea, then we're pretty happy with that. Ideally, we would be comfortable somewhere in the 200 to 300 micron range is what we're normally targeting. Now, when we allow for the settling, what we want to see is, do we have vault through the peripheral cornea and limbus prior to settling, and then very importantly after the settling, do we see if that lens has settled into touch? If your scleral lenses land on cornea, then it's often possible that they'll get some staining. So it's really good if we can see after settling we have no peripheral corneal or limbal bearing. Then the next section of the lens that we're concerned with is how does it land? Do we see any blockage of the vessels at the lens edge? Is our edge effectively too tight? And is it sealing off the vessel flow of any of the small or large capillaries? There's our temporal side. And here's our nasal side. Again, look at these small and large capillaries just running right past the lens edge. Generally, you get the backup. If there's going to be a problem, it'll be right at the edge. We might be concerned with this vessel, but it appears that it seems to dig deep or sink below the surface before the lens edge, so it's not likely from a tight ICD fit. So on this patient, we've got a 4,500 micron lens with 200 microns of post-settling apical clearance. The limbal clearance area looks fairly thin. We see that on the OCT here, and we also see that in the slit lamp. It looks like we could afford a little more vault through that peripheral cornea and limbus. So that would lead us to increase the limbal clearance zone in the lens. And a 5-step adjustment would increase the depth 125 microns. So by increasing our limbal clearance zone 5 steps, that would add 125 microns to the apical clearance, giving us a total of 325 microns of apical clearance. We'll talk more about how the limbal clearance zone changes affect the sagittal depth of our lens, but that's generally how we would approach the fit. Start with the sagittal depth of lens that gives you a healthy amount of fluid, no corneal bearing, then measure the apical clearance, then observe the limbal clearance post-settling, and observe the landing of the lens post-settling. So one of the significant benefits of scleral lenses is it really doesn't matter what the corneal shape is. We're going to vault over top of that asymmetrical eye and make it easy for us by landing out on the symmetrical sclera. So when we have a case like a pellucid marginal degeneration that has 9 1/4 diopters of against the rule irregular astigmatism is what this pellucid patient had, we would go straight to a scleral lens, especially if the theoretical fluorescein pattern in our topography software showed us a landing at 12 and 6 o'clock and a massive amount of fluid all the way around where we wouldn't be able to fix that with any kind of modification to our corneal GP lens. Now, why else are scleral lenses beneficial to us? And in ocular surface disease, they're being used more with greater frequency. And here's an example where we had a patient that came in severe pain. With each blink, it was like needles to the eye. And after 2 months in the ICD, you can see the recovery of the corneal surface. But what you can't see in these images is how this patient was able to walk in under their own direction without bringing somebody to walk them through the door. There was actually a smile on the face where previously this patient was in such severe pain and life was very, very difficult for these patients. So scleral lenses are fabulous for patients with ocular surface disease as a way of providing relief. Because you create that vaulting of fluid between lens and cornea, you're protecting the surface of the eye. Now, some of the things that might be helpful to understand prior to discussing the makeup of the ICD is what we know about the shape of the eye. And one of the studies that Patrick Caroline at Pacific University has led us to evaluate is, with OCT, what is the underlying shape that we actually land on with our scleral lens? And one of the first studies that we did was to look at the angles that form through 10 millimeters across the corneal surface to 15 millimeters across the sclera. And what is the angle that begins to form? Notice how the eye surface is very straight line or tangent in shape. It doesn't have curve. The cornea more curved, but the peripheral cornea, limbus, and sclera become a little more straight lined or tangent in shape. Then we also measured the angles that formed from 15 millimeters to 20 millimeters to see how different this angle in cornea and sclera was different from this angle completely on the sclera. And what we learned was at the 15 millimeter diameter, the 15 millimeter chord, the eye has about 1.7 degrees of differential. The eye is fairly symmetrical at 15 millimeters out. At 20 millimeters, this outer annulus, the eye begins to have much more asymmetry. There's 6.6 degrees of asymmetry out there. So that indicates to us that if we're dealing with scleral lenses that land closer to 15 millimeters, then we should be able to get away with symmetrical, non-toric scleral lenses. If we go out larger toward the 20 millimeter chord, then we may need more asymmetrical surfaces because the eye, the sclera, is more asymmetrical out there. One of the next studies that we looked at was how much toricity is there. Angles mean very little to most of us in practice. So what's another way we could look at the shape of the sclera? And what we did was we took the 13 millimeter diameter and the 15 millimeter diameter across the sclera and measured the height of the eye across the horizontal and the vertical meridian. So what we were curious of is, what is the depth of the eye this way compared to the depth of the eye this way? Is the sclera effectively with the rule or against the rule? And what we found was that the majority of patients that we saw had with the rule scleral shape. And at the 13 millimeter diameter, the eye depth across the vertical is approximately 95 microns deeper than the depth across the horizontal meridian, meaning that our scleral lenses should land heaviest across 3 and 9 o'clock. That's where we should see the vast majority of the blanching or bearing, or if we have a tight fit, it's probably going to be horizontal. At the 15 millimeter chord, at slightly farther out, we see a little more toricity, meaning that the eye depth at 15 millimeters out was 156 microns greater across the vertical. So again, the scleras at 13 millimeters and 15 millimeters show with the rule toricity, with the vertical meridian being deeper. This patient you're looking at here is one of the exceptions to the rule. It's pretty rare, but occasionally you'll run into a patient with against the rule scleral shape, and this is a patient where the lens is actually landing at 12 and 6 o'clock and you can see no bearing across the horizontal meridian. This same patient was also very abnormal in that they had 500 microns of toricity. The eye depth was 500 microns deeper this way than it was this way, whereas the normal amount of toricity would be around 150 microns. This patient had 500 microns more depth. So it does come up that you need a more toric type landing of your scleral lenses, but typically a symmetrical lens on most eyes is going to work quite well, and I would guesstimate better than 95% of eyes can be fit with a symmetrical lens. Now, why is this scleral lens riding slightly low? What's contributing to this lens wanting to decenter? Is it corneal asymmetry? Is it a deep displaced corneal apex? Well, if our scleral lens is vaulting the cornea, then really the apex of the eye really matters very little. So why then do we see on this left eye that this lens is riding a little bit toward the low side? And that may be because the majority of scleras that we see are with the rule, with the vertical meridian being deeper. Then we have lid force and gravity pulling the lens down. So it's very routine to see some thinning or possibly touch in your scleral lens fits. Because you're dealing with a toric sclera, you're dealing with lid force, and you're dealing with gravity. As long as post-removal you don't see any staining here, we don't worry too much about any peripheral corneal thinning of the fluid, but we'll talk a little bit more about that as we move forward. Now you'll also notice with your scleral lenses, and the ICD is no different, that you see some nasal thinning. Notice this is a right eye, and we've got this thinning of the fluid on the nasal side where we seem to have quite a volume of fluid on the temporal side. We can also look at the edge of the lens appearing closer to the visible iris here versus much farther away on the other side. So the lens appears slightly temporal. Is that why we see this thinning? And why is the lens riding temporal? Is it an against the rule scleral shape? Is it some kind of lid force? Is it a displaced corneal apex? Well, one of the things that's beneficial to know is in a follow-up study that we did at Pacific University, we found that with OCT, the nasal aspect of the eye at the 15 millimeter chord was much higher in elevation than the temporal side was. In other words, when we drop a contact lens on a patient that lands on the sclera, it should hit first on the nasal side because its elevation is higher. Then there's this greater vault or greater drop on the temporal side, which would cause the lens to fall more temporally. And that may be why we see this nasal thinning with all this temporal vault. Nasal side higher, temporal side lower. With the nasal side being higher, that also might contribute to the lens decentering slightly temporal as well. So I think what we're seeing is that when we drop our ICD and all our scleral lenses on eye, they're going to hit on that higher nasal aspect. Then they're going to have to fall on the temporal side because the drop in elevation is much lower on that temporal side. Now let's talk about the zones of the ICD lens. There are three principal zones that you'll hear discussed in many of the webinars and in a lot of the materials that come from Paragon, but there's actually four zones in the lens. The second zone, the peripheral corneal clearance zone, is discussed very little, but what it does is it raises or lowers the center of the lens. You don't often have to change it, but it's helpful to know it's there. The limbal clearance zone would increase the vault that you're seeing over the limbus, and then of course the scleral landing zone would be where our lens lands on the eye surface. So let's go through each one of these zones and discuss how we would assess the fit of the lens. The first thing that we do is when we place an ICD lens on eye, what we're looking for is good corneal vault. We see no point of bearing with the corneal surface, and if we've put enough fluorescein in behind the lens, we should have a difficult time making out any corneal anatomy, any anatomy, iris or pupil. In this case, you see lots of fluid throughout the central corneal clearance zone. It looks like we've got a lens that we can say at least has enough apical clearance on insertion. What we don't know is how much clearance actually exists. So we'll do an optic section in the exam to verify that. But step number one is verify that your central corneal clearance is appropriate, that you've got basically enough vault. The next zone in the lens is to assess the limbal clearance, and what we do is switch over to white light and look at the bleed of these fluorescein molecules through the peripheral cornea, past the limbus, and onto the sclera. And do we see that vault 360 degrees around? Are we protecting those delicate limbal stem cells by vaulting our lens through this delicate zone? And basically what we're hoping to see is a lens that has its vault through the central cornea. Then the limbal clearance zone brings the lens toward the sclera before you land, and we're hoping to vault right through the limbus. Then the next zone in the lens is your scleral landing zone, and what we're looking for here is in white light we want to see those fluorescein molecules pushed out where the contact lens lands on the conjunctival surface and aligns itself 360 degrees around. So notice how it's very difficult to make out any fluorescein molecules 360 degrees around the clock. And that's what we're looking for. If we have an appropriate landing of our scleral lens, we should see those small and large capillaries just running right past the lens edge. We're creating a very healthy landing of our lens on the surface of the conj. And you can look at the OCT images down here. When you have an appropriate landing, your lens should sit up high and proud, landing right in the middle of the scleral landing zone. You see at the edge, it hasn't dug itself into the conj. The contact lens, the ICD lens edge, is not pointing in toward the corneal surface. It's pointing along the conjunctival surface. So this is an appropriate landing that we see on nasal and temporal sides, where our scleral landing zone is hitting right in the middle of that zone and creating a beautiful distribution of the force on either side of the point of greatest bearing. Once we've put that lens on eye, we want to verify that we have an appropriate apical clearance. If you have a pattern like this, right off the bat you're pretty happy because you know you don't have to put on another trial lens. We've got plenty of corneal vault. We can't see any lens bearing or any thinning in the pattern that might indicate the lens could settle into touch. In this fit in the lower left, we've got this heavy, or what appears to be a heavy, point of bearing on the cone. This lens, if it were clearing, would not allow for any lens settling. If that lens sinks itself into the conj, and this is not touch, it very soon will be touch after that lens settles. So in this case, you would need to put on a higher depth lens, and we would suggest going 300 to 400 microns higher in depth to make sure you've got that 300 to 400 microns of vault on insertion. And then this fit here, it could be the appropriate apical clearance, or maybe we didn't put enough fluorescein in behind the lens. So did this lens have a lot of fluorescein? If it did, and we're making out anatomy of the eye, then possibly we need to go to a higher depth lens. So we'll definitely need to check the optic section here to make sure that the fluorescein isn't misleading us, but it appears that this lens might not have enough depth. We need to put on another lens. So the upper right image is what we're looking for on insertion. Now, how do you know how much apical clearance you have? And this is really simple. You know that the ICD lens is 0.3 millimeters thick, or 300 microns thick. So if you pull up your optic section and look at your lens with, there's the anterior surface fluorescein right here. There's the ICD lens, your GP. There's the posterior fluid layer between cornea and lens. And what you're looking for is about an equal amount of fluid to the thickness of the lens. In this case, we might say that the fluid thickness here appears fairly close to the thickness of our lens, so it's about 300 microns. Over the cone, it might be getting a little bit thinner down there, maybe 200 microns, maybe 250 microns of fluid in this area. In this optic section, you see your anterior surface fluid, then you see your lens, and here is our posterior fluid. If this is 300 microns, then this must be at least 600 microns of fluid. So use your optic section to determine how much apical clearance you have. If you have an OCT, it's another way that you can be fairly accurate to within microns or tens of microns how much apical clearance that you have. Now, why do we want so much on insertion? Why shoot for 300 to 400 microns of fluid on insertion? And part of the reason is that scleral lenses settle into that boggy conjunctival surface. It's like a sponge, and it just allows that lens to sink right in. One of our first studies at Pacific University was to look at the apical clearance on insertion on 15 healthy students. So these are healthy eyes. And what we found was on insertion we had 316 microns of apical clearance. Post-settling, we measured after 8 hours of wear, 220 microns on average of apical clearance, or a settling of approximately 96 microns. So the lenses over an 8-hour period on average settled about 100 microns on the healthy eye. Makes you wonder how much would they settle on the diseased eye or an ocular surface issue patient, or a keratoconic, or a penetrating keratoplasty. Notice also that the range was huge, 50 to 180 microns. So if you put on a lens with 400 microns of apical clearance and it sinks 180 microns, you're left with 220 microns of fluid, a fairly healthy amount of fluid between lens and cornea. So when in doubt, we err toward the high side on apical clearance. And that initial study was followed up by others. The second study that we did looked at a similar number of patients. It was around 15, and over an 8-hour period we found in the second study the average settling was about 127 microns of loss in apical clearance. So the lenses sunk into the conj by about 127 microns over 8 hours. Our colleague, one of the co-designers of the ICD lens, John Mountford, did this awesome study over years of analysis. I believe it was 2 years he followed his ICD wearers, and I believe it was 492 eyes that John had fit. And he looked at 30-day settling, where the two Pacific studies were over an 8-hour period. He looked at the settling that happened between insertion and after 30 days of wear. And he found the average settling of the ICD was around 146 microns. So this is why we shoot for so much apical clearance, 400 microns on insertion, because John's study showed that over the course of time, those lenses settle even more. If we start with 400 and we lose 150, we're left with 250 microns. An interesting thing in John's study was also that he found the range of settling for all his patients was between 50 and 250 microns. So some of the patients saw settling of 250 microns. So if you start with only 200 microns of apical clearance, you may not have enough vault in there to allow for the kind of settling that will happen for some patients. Now let's focus for a second on the limbal clearance zone. This is an area that I felt very confused in the beginning by how much and how often do we need to change the limbal clearance. And if you look at this patient, you've got this beautiful vault, 360 degrees throughout the limbus. I'd like to tell you that this is the typical patient, but it's not. It's not typical to see this beautiful landing 360 degrees with the vault running all the way through the limbus all the way around. Often we see that nasal thinning and slight superior thinning of the fluid. And this is the kind of pattern that we will often see. This is a left eye. You can always tell because you get the nasal, or generally you get the thinning on the nasal aspect. Then we also get this arcuate thinning throughout the superior area too. Now, is this a patient that we should be changing the limbal clearance? Do we need to adjust this vault here? And to be honest, we found this very confusing in the beginning. And it was because we didn't understand the underlying shape of the sclera when we started fitting scleral lenses. The nasal aspect higher than the temporal aspect. So that's why we see the thinning here, the greater vault here. That's why we see the lens appearing to position more temporal and more inferior. So when you're in doubt, do I need to call up the lab and order a lens with an increased limbal clearance zone? Do the simple test. Have the patient look in the opposite direction to the bearing. So if you see that thinning or possible bearing, have the patient look down. As the lens skirts up slightly, if you see that beautiful vault through that area where you previously had the thinning in primary gaze, you know you don't need to worry about it. Same thing here. We've got the thinning on the nasal side. Let's ask the patient to look temporal and see how much vault we get through here. And again, it appears not to be an issue. So the rule of thumb that we use at Pacific University is if there is less than 180 degrees of this thinning, we just let the patient go. We'll have the patient back in after a full day of wear, and we'll want to pull the lens off, stain the cornea, and make sure that we don't have any ruffling of epithelium here, that isn't in fact vault, that it's possibly touch. So if in doubt, if it's less than 180 degrees of thinning, probably not an issue. But do the fixation change test to see if with that slight change in fixation, the lens appears to vault. If you had greater than 180 degrees of bearing or thinning, and you do the fixation change test, you're often going to see that bearing just doesn't go away, and it's because this is simply a high point, or we don't have enough vault in our limbal clearance zone. When the lenses are inserted, often you'll see a nice fluid layer running all the way through the peripheral cornea and limbus. But after those lenses settle into that boggy conj, we lose some of that peripheral corneal and limbal vaulting that we have. Now, is it a problem to have some limbal and peripheral corneal touch? It may not be, but we're trying to be safe by vaulting through that area. And you may find if your lenses land down on peripheral cornea, they start rubbing on the cornea there, and they may create some disruption in epithelium. So by vaulting, you're just assuring yourself that you've got a safe and healthy fit. Now, how do we adjust this? How do we take a lens that looks like this with this peripheral corneal and limbal vault and create a more healthy tier layer between lens and surface? Well, by changing the limbal clearance zone, 5 steps is the typical adjustment. What you're simply doing is taking the angle of that zone and increasing it, making that angle higher. The higher you make the angle, the greater you're going to vault. Again, the typical adjustment, if you had thinning through the limbal clearance zone, such as you see here, is to ask for, from the lab, a limbal clearance zone plus 5. Remember that as you increase that angle, increase that vault, each step equals 25 microns in additional sagittal depth. So a 5-step adjustment would create 125 microns more sagittal depth at the peak. So that's something to keep in the back of your mind when you're making your adjustments. If you already have excessive apical clearance, but you need more limbal clearance, you may need to call the lab and have them adjust that peripheral corneal clearance zone to compensate for this increased vault you're creating at the limbus. Now here would be an example where we might have a very thin limbal clearance zone or vault through the peripheral cornea and limbus. By changing that angle, you increase the vault and create a much healthier lens to cornea relationship or lens to surface relationship. Notice the increased vaulting both through the peripheral cornea and limbus, but also by adding clearance zone, you've added 125 microns more sagittal depth. So if you would then have an excessive amount of apical clearance, the lab can just compensate by modifying that next zone in the lens and dropping the center ever so slightly. The next zone in the lens that we're concerned with is that scleral landing zone, as we discussed earlier. And what we want to see is that throughout this zone, 360 degrees around, we don't have any constriction of the vessels. We're not sealing off any of the vessel supply through that lens edge. And it's typical to see more bearing at 3 and 9 o'clock, or more blanching at 3 and 9 o'clock, more sealing off of the vessels at 3 and 9, because you have the lowest elevation in most corneas. If the sclera is with the rule, then your axis of greatest bearing would be 3 and 9 o'clock. your axis of greatest lift, or the least amount of bearing, should be at 12 and 6 o'clock. So it's very routine to see any blanching that exists would be at 3 and 9. And here's an example where our lens edge is sinking into the conj too much and creating this backup. This would require a call to the lab and asking them for an increased edge lift in the scleral landing zone. Now, why does this happen? Why do we get the seal off of vessels right there at the edge? And if you look at OCT, which is so fabulous at showing us how these lenses land out there where we really can't see with the slit lamp how they touch down. The OCT shows us that this lens is pointing in toward the conjunctival surface. It's not pointing along the surface. It's not running parallel to the underlying shape of the eye. It's landing toward with its nose tipped or pointed in, and that's what creates the blanching. If your edge is pointing along the conjunctival surface, then you generally won't have any blanching whatsoever. You get this wide distribution of pressure. So if you have a case like this where your tip or this angle is simply too aggressive or too steep for the surface it's landing on, call up the lab and they'll create a flatter angle, raise that tip of the edge up so that you've got this more parallel relationship of scleral landing zone to underlying surface of eye. Now, how do you fit the ICD? You have multiple methods. You can use the keratometer, you can use the topographer, you can even use the OCT. Now, as far as overrefraction over these lenses, simple spheral cylinder overrefraction is how you would fit the lens. And generally, a front toric type ICD lens is not required. You can generally get away with spheral cylinder overrefraction, and that's usually because most of the irregularity we're dealing with is on the corneal surface, and our scleral lenses, of course, would neutralize with lens and fluid that irregularity. Now here's the tools that we need. We need preservative-free saline for insertion. We don't want to put any preservative trapped between lens and cornea that is left there throughout the day for 16 hours. So you want preservative-free fluid. In this case, we use in North America in most offices inhalation solution nebulizer fluid from the pharmacist. 5 milliliter vial for your binocular fits, 3 milliliter vial for your monocular fits. We also use both DMVs. The large DMV for insertion creates a very stable platform to insert the lens. We'll cut off the tip and take away the suction because we really don't use this for removal. It's used only for insertion, and just by placing the lens in the cup here, it'll be very stable. You don't need any suction force. What we don't want is for a patient that's struggling with the initial insertion, they're new to scleral lenses, they're new to maybe contact lenses, we don't want the lens being stuck on the suction cup the second they place it on eye. If the suction is gone, as soon as the fluid squeezes itself out, then that lens will stay on eye. But you do want the smaller DMV. We use the 45 degree so that the patient can see the DMV coming toward their eye and they just place it on the inferior portion of the lens. The 45 degree is a little more beneficial for removal that way. Now we also need our GP fluid. Why? Because we want to do our surfactant cleaning with the GP cleaner, and then we store the lens overnight in our conditioning solution. What we don't kill with the surfactant cleaning hopefully will kill whatever bugs are left over with the overnight conditioning of the lens. Now when you do your fluorescein, you cannot get enough fluorescein under the lens after it's been placed on eye. These lenses quickly sink into that boggy conj, so it's difficult to push fluorescein underneath these lenses. So what you want to do is fill up the bowl full of fluid and then place your your fluorescein in prior to removal. And whatever amount of fluorescein you think you need, use much, much more than that, because the majority of it you're going to squeeze out. If this is a 4,500 micron lens and you fill up the bowl full of fluid, then you use your fluorescein strip and place that lens on eye. Of that 4,500 microns of fluid and fluorescein between lens and cornea, you're going to squeeze the majority of that out and leave only 400 microns of your 4,500, and you're going to have very little of the fluorescein left. So put lots and lots of fluorescein in the bowl prior to insertion. And here's an example where if we were to fluoresce a corneal GP on eye, it has only a 20 to maybe at the most 100 micron level of fluid between lens and cornea, whereas a scleral lens would have maybe 400 microns on insertion. If we inserted the wrong lens, maybe 600 microns on insertion. So we need much more fluorescein between lens and cornea to pick up those molecules. Now, as we said earlier, fill up the bowl full of fluid prior to insertion with the preservative-free saline, then fluoresce that bowl. And the majority of the fluorescein, again, is going to be squeezed out, so use lots and lots and lots. And then have the patient lean over so they're looking parallel to the ground, and we have the patient pull up on their upper lid while we have the patient pull down on their lower lid while we'll pull up on their upper lid and then bring the lens up toward the surface of the eye. If you have an experienced contact lens wearer, they may be able to do it themselves, but generally just having them pull down on their lower lid, we reach around, pull up on the upper lid, and bring the lens up toward the surface of the eye. In the beginning, we used to have the patient in the chair, and we'd crank up the chair to the maximum height, and that way we didn't have to bend down to the ground to get it on eye. More recently, we're having the patient stand and just lean forward, and we find that an easier way for both patient and practitioner, and all the fluorescein doesn't end up on their lap. So the principal things we need to look at when we analyze these lenses are make sure that you allow that 60 minutes of settling. That's really, really important. If you can go longer, do it. As John's study showed us, these lenses don't only settle just over the course of the day, they settle over the course of time, up to 30 days. So the longer we allow these lenses to settle, the clearer the picture is going to be of apical clearance, of limbal clearance, of scleral landing. And what you don't want is to rush to a decision on a custom ICD lens and have that edge come out a little bit too tight because we didn't allow enough settling time to determine that this patient's scleral shape was actually quite flat and we needed a increased scleral landing zone lift. Make sure that the patient rinses off the conditioning solution from the night before with their preservative-free saline. They don't insert the lens with any preservative on the back surface, and that'll reduce any solution toxicities that the patient might have from the long hours of wear during the day. And if you see any blanching or any angry red eyes, these are things that we need to immediately adjust for. Although some clinicians will tell you that if there's less than 30 degrees of blanching, it may be something you can dispense and just monitor. We're trying to eliminate 100% of the blanching if possible. Now, what are the things, the principal things we're looking at when we fit this lens? Just as a reminder, we want a central clearance zone that shows good corneal vault as we place that lens on eye for insertion, and similarly after it's settled, we have a difficult time making out any corneal anatomy or any, eye anatomy, pupil or iris. Then we'll pull up our optic section. If we have 600 microns of fluid with the diagnostic lens, if you're crunched for time, you don't necessarily need to put on another lens. It's beneficial to do it, but you can always order up from the lab a lens with 300 microns less apical clearance. Just simply call your ICD consultant and ask them to take the lens you have, be it a 4500 or whatever, and ask them to reduce the sagittal depth of that lens by the measured amount we require. So I'm always comfortable with a lens that goes on with too much apical clearance. A lens that goes on with an inadequate amount of clearance probably needs to come off and a higher depth lens placed on eye because it may not allow for settling. Then check out your limbal clearance zone and make sure that you've got good vault 360 degrees around. If you don't on the nasal side, if you see some nasal superior thinning, check the centration of the lens. Does it appear to be going slightly temporal? If it is, then that's going to thin the fluid out on the nasal side. Is it similarly riding slightly low? That will thin out the fluid at 12 o'clock. If you're seeing that thinning and you're not sure if you're comfortable with that thinning, then do that fixation change. If you've got nasal thinning, have the patient look temporal and see if that lens skirts slightly nasal and we get that vault that we're looking for. If we have superior thinning, have the patient look down and see if you get the vault up there at 12 o'clock. Then the last thing that we're really concerned with is the landing of the lens. So we can do that in white light or in cobalt, but we're wanting to make sure we're seeing a healthy flow of the vessels throughout the lens edge. And this may be the Achilles heel of scleral lenses. This is where we probably run into the most troubles, where we're likely modifying from the trial lens specs. So if your trial lens isn't going to work 100% for the patient, it's probably a scleral landing zone adjustment that we need to make to optimize the final custom order for the patient. Now, with a sealed scleral lens, often you'll find that as it seals itself 360 degrees around and creates a negative suction force with the fluid, if your patient is having trouble popping that lens off, what you might find it easy to do, or makes it easier for the patient to remove it, is create a removal bubble. And what you do is you have the patient press with their finger into their lower lid below the contact lens, below the ICD, so they create a gap between the surface of the conj and the lens. And as soon as they've created enough gap, then the bubble will shoot its way in there. Once the bubble's in there, then you've broken the negative pressure that exists between lens and cornea, and the lens should pop out quite easily. So if you're having trouble with removal, maybe it's a patient that has that significant 250 microns of sinking into the conj, that's a patient that you would have them push into the lower lid below the lens, not on the lens, but below the lens, keeping a gap between lens and cornea. And the patient will know the second that bubble gets in there because their vision will change. And then once the bubble's in there, the DMV is often very easy to remove it. Remember that your ICD comes in different sagittal depths, 3,900 microns, then up to 4,000, 41, 42, 43. It keeps going up by 100 micron increments. If you have if keratometer is the only method you have of fitting your ICD lenses, then think about the condition you're dealing with. If it's a normal shape eye, then you would go right to the 4,200 micron lens. If it's a keratoconic, you're going to go up higher, the 45. If it's a transplant, you're going to go another 300 microns higher. So this method is quite effective for the majority of patients. But if you want to be a little more scientific, if your topographer has the ability to measure sagittal depth across a chord of 10 millimeters, so meaning if we can measure the depth of the eye across 10 millimeters of the cornea, then we've got a metric to calculate the final IC, or the custom, the trial ICD lens. In this case, our corneal topographer told us that the sagittal depth of the cornea was 2,300 microns. We know the average depth of the anterior chamber from 10 millimeters, where the topographer measures to to 15 millimeters, beyond where the topographer will measure, averages about 2,000 microns. In other words, if our corneal topographer can measure the corneal sagittal depth, then we can use this 2,000 microns as an average depth of the anterior chamber. Then you add in your apical clearance, and that gives you the final lens you need. So this patient is 2,300 microns corneal sag, plus 2,000 microns for the scleral sag factor. That gives us 4,300 microns. Plus we want an apical clearance of 400 microns on insertion, and that gives us an ICD trial of 4,700. So what if we blow it and we put on a lens far too low in sagittal depth? Instead of the 4,700 micron lens, we put on the 4,300 micron lens, 400 microns lower. In this case, the lens looks like it vaulted central corneal tissue by enough. Now have a look at this pattern. How much fluid do you think exists between lens and cornea? How much would you guesstimate? Remember that we should have put on a 4,700 micron lens. We put on a lens 400 microns lower. Yet we have a very difficult time making out pupil or iris here. When you pull up the OCT, this patient has actually 200 microns of fluid between lens and cornea. So the depth of this eye must have been much lower than we anticipated, because even with a lens that was far too low for this eye in theory, we still ended up with some fluid between lens and cornea. Probably the minimum amount of fluid we'd be comfortable with on insertion. If we had under 200 microns of fluid on insertion, we should probably put in another trial lens, go up by 100 or 200 microns. Here's the same patient after 4 hours of settling. Notice again the central clearance of the lens. Looks like there's plenty of fluid between lens and cornea. When you pull up the OCT, that lens is actually sunk to only 110 microns of apical clearance. Isn't it interesting how much fluid this slit lamp image would appear to have, yet we're down to only 110 microns. So the slit lamp image in the open beam can be kind of misleading, and that's why the optic section or your OCT is really helpful. Clearly this lens could use more apical clearance, especially if we're dealing with a keratoconic eye where we might have a high point somewhere in the surface, or a penetrating keratoplasty where there's multiple high points. We can look at the OCT on insertion. There's plenty of fluid between lens and peripheral cornea, limbus, and the initial part of the sclera. But after settling on the left eye, it's settled just near the limbus, but not quite into the peripheral cornea. So on the temporal side, it's okay. And again, it's because we often see the lenses riding slightly temporal. Then on the nasal side, we've got the lens on insertion sitting up high and proud, but notice what happens after settling. That lens sinks itself in to that very soft, boggy conj, and we've actually lost a lot of that limbal, that peripheral cornea and limbal clearance we had. It's now turned into touch. So this lens might require some modification. We might want to call up our ICD distributor and increase that vault. When we pull up the optic section, the optic section is saying that it looks like there might be 200 microns of fluid, although the OCT showed maybe 100, but definitely we're seeing less fluid here. This might be in the 100 micron range. So compare the anterior surface fluid versus your 300 microns of lens, and that will tell you how much posterior surface fluid you have. Then check your edge. Make sure that you're not seeing any sealing off of these vessels. Looking good on the nasal side. Again, that one vessel seems to go quite deep and then comes back up again right at the lens edge. On the opposing side, you see this beautiful appearance of all the vessels all the way around. and there's our patient after 4 hours of settling. And this is what's interesting, is that nasal aspect. Look at the thinning of fluid here that's running through the nasal superior area. Do you need to change this vault? And if you look out here on the conj, it looks like we can see fluorescein molecules here. We can see fluorescein molecules here. So is this bearing, or is it thinning of the fluid? And that's where it can get a little gray. So if you're not sure or you're not comfortable, then just call up the lab and order a Limbal clearance zone +5. Increase that vault through that area. If the lens continues to have that temporal inferior decentration, then even after you increase the limbal clearance zone, you may still see some of that arcuate thinning. So if you're worried about it, then have the patient wear the lens for a good portion of the day, come back, pull the lens off, stain the cornea. If you're seeing a clear cornea, you know you don't need to worry about it. That this isn't actually touch, it's just thin. Thinner amount of fluid than what we see here or what we see here. Now, the ICD is distributed throughout the world. Here's some of the distributors. I know we have people on board here tonight that are in Europe, in Australia, and throughout the globe. So if you happen to be a American practitioner, you can see there's a number of labs in the US. In Canada, Precision Technology is the ICD distributor. In Australia, it's Capricornia, LCS in France, Lenticon Spain, number 7 in the UK, Soflex in Israel, and TS Lenti in Italy. If you want to do this video again, it will be recorded and placed on the YouTube site for Precision Technology. In other words, if you go to YouTube, look up Precision Technology, you'll find this video posted in the next week or so. You'll also see the other 5 videos, the other 4 videos that were done up to this point on various specialty contact lens related topics. The next webinar is going to be on corneal topography, and we're going to tie in all the lenses discussed from webinars 1 through 5 and how we would use the corneal topographer to optimize the fit of whichever contact lens we were fitting. So by registering and attending tonight, you'll automatically receive the invitation for webinar 6 on corneal topography if you're interested. This might be a little short notice for many of you, and it might be too far across the ocean for a good portion, but for those of you who happen to be in Canada or nearby, in Toronto and Vancouver this weekend and Toronto the following weekend, we're having a myopia control workshop, and in that workshop we're also discussing scleral lens fitting. So if you happen to be available and interested, it's a 9-hour COPE CE workshop on orthokeratology, on using multifocal contact lenses in myopia control, and on scleral lenses. And Patrick Caroline from Pacific University, as well as myself, will both be the speakers for that workshop. I'd like to thank you for logging in tonight. If you're interested, we're going to go through the questions in the next period after the session closes, so just hang in there with us. But before I shut down this main part of the webinar, I'd just like to thank you for spending time with us tonight, and also to acknowledge Precision Technology and Paragon Vision Sciences for sponsoring tonight's webinar on the ICD.